So it gives me great pleasure to introduce our next speaker, Dr. Sunil Rao, who is very well known to most of you. Dr. Rao is a professor in Duke University and chief of cardiology at the VA and one of the world leaders on bleeding prevention strategies. And he'll talk to us about the role of atherectomy for complex PCI.
Thanks very much, Manos. Thanks, Subhash and Manos, for the invitation to this great meeting. You know, I want to take a few seconds just to tell everyone, you know, how important the role of Subhash and Manos has been in interventional cardiology over the last 10 years. I certainly call them probably on a monthly basis, if not a weekly basis, for advice on things. And I've actually sent several cases to them from our VA to their VA to get complex CTOs done. So it's a real privilege for me to be part of this conference. They asked me to talk a little bit about atherectomy and complete revascularization. And I think, as Shami said earlier, this probably would have been a relatively short talk until recently, because primarily the use of atherectomy has fallen in the United States. But now, as I'll talk to you about, we actually have two platforms now, and I think the use of atherectomy is going up, primarily because the kinds of cases that we're seeing in our cath labs, and you've seen some of those in the previous talks. These are my disclosures. The one that's relevant to this is I am a consultant for CSI, which makes orbital atherectomy. So I think, you know, we're all data-driven. We all want to practice evidence-based medicine. But I think sometimes when we're faced with cases in the cath lab, the issue really is to keep in mind what our goals of therapy are. And the goals of therapy and the kinds of patients that we're talking about this evening is primarily to improve symptoms and quality of life, which I think have derisively been referred to as soft endpoints, but they're certainly not soft to patients. And then ultimately, we do want to improve prognosis by reducing death and reducing the risk for myocardial infarction. But in order to achieve those endpoints in the kinds of patients that you've seen today, we have to be able to do revascularization with high quality and durability. And that revascularization has to be performed on lesions that are causing symptoms or causing a reduction in quality of life. So just because the lesion is harder to treat, so if it's heavily calcified, it's extremely tortuous, it doesn't mean that the indications to do the case have changed. With current technology, and you've seen some of that technology this evening, and I'm talking about atherectomy, you can get these cases done and have successful outcomes, and patients can have improved quality of life. Because the risk-benefit equation can be modified with training, the correct technical advances, and the appropriate devices and equipment, and atherectomy is integral to that entire equation. So here's a case. This is a 69-year-old patient that was transferred from an outside hospital for PCI after presenting there with a non-STEMI. He had a history of 3-vessel CABG 25 years ago. He had an edema of the LAD, a vein graft to the OM, and a vein to the right PDA. He had had stuttering chest pain for 1 to 2 days, and he was made pain-free with dual antiplatelet therapy, IV heparin, IV nitro, and his troponin I was elevated to 6. You know, just as an aside, when I was on service this week, and I was talking to the residents in the CCU, and you know, they're all worried when patients have these big MIs of troponins of 2. And I said, you know, when I trained, we didn't have troponins, and we had CKMBs of 230. That's a big MI. So there's big and there's really big. So he was taken to the cath lab the next day, where his lima was found to be open, but all his other grafts were down. He had an IVUS of the left main ostium. You'll see it the angiographically what it looks like, but it looked okay by IVUS. The cross-sectional area was 7.1, but the entire circumflex distribution was jeopardized, and he was transferred for PCI. Here you can see what this looks like. He's got a very tight distal left main lesion, which is heavily calcified. You can see the calcium just during the cardiac cycle without any contrast in the coronaries, and you can see that the circumflex there is basically a thread with TIMI, I guess, 1.8 flow there. So that was our target. So let's talk a little bit about calcified lesions, because calcification in the presence of the coronary, we know as interventional cardiologists, will make our day a little bit longer, make our job a little bit harder, and make the stent outcomes a little bit worse. And this is actually borne out now by data. This is from Philippe Generoux's core lab at Cardiovascular Research Foundation, where he looked at 3 data sets, 2 data sets, one combined from Horizons and Acuity. Interestingly, Horizons is a STEMI trial, and Acuity was a non-STEMI trial. But patients with STEMI oftentimes also have calcification. And you can see that there's a stepwise increase in the incidence of adverse events as coronary calcification goes from not having any or mild calcification, moderate or severe, and there are specific definitions for this. Severe primarily being that you can see the calcification with the cardiac cycle without contrast. And similarly, in the ADAPT-DES registry, which is a registry designed to examine the real-world outcomes of drug-eluting stents, you can see that there's a strong association between the presence of coronary calcification and death. death or MI, target vessel failure, and major adverse cardiac events. The biggest issue for us, I think, in the cath lab is obtaining an optimal stent result. Calcification limits the apposition of stents and limits the expansion of stents. So what are our atherectomy options in the current era? Well, there's directional atherectomy, which we really don't use anymore. There's rotational atherectomy, and now there's orbital atherectomy. So I'll say that in the CHIP context, in this complex high-risk indicated patients, the three goals in the cath lab are successful PCI, no complications, and a durable long-term result. And the use of atherectomy in the appropriate patients can help you achieve all three of those goals. So let's talk a little bit about Rotablator. This was approved in June of 1993. This is directly from the Gray Sheet, which is a device newsletter, and talking about the indications for use for Rotablator. And I don't know how many people know this, but rotational atherectomy was never actually FDA approved for calcification. It was the wording of the IFU is that the device can be used as sole therapy or with the adjunctive balloon angioplasty in patients with coronary artery disease who are also candidates for coronary artery bypass surgery. So obviously this is what I was referring to when I said that I'd be talking about off-label indications in my disclosure slide. This is certainly not how we use Rotablator these days, but that's what it was originally indicated for. There are some randomized trials of Rotablator. These are in primarily the balloon angioplasty era, some in the DES era. The early trial, you can see that the sample sizes of these are actually not bad for a device like atherectomy. Similar rates of procedure success and complications compared with balloon angioplasty. This is pre-stent. What's interesting is that the use of aggressive, large burrs did not seem to provide a favorable prognosis compared with just using standard burr sizes and using balloon angioplasty, which is why oftentimes we will try to avoid upsizing burrs now. When looking at the use of rotational atherectomy and drug-eluting stents, there was greater acute gain, but ultimately there was no difference in 9-month outcomes. Now, the most contemporary data is a Rotaxis trial, which is 240 patients with calcified lesions randomized to rotational atherectomy plus the paclitaxel-eluting stent versus just plain old balloon angioplasty and the paclitaxel-eluting stent with clinical follow-up at 9 months. So what's interesting here is that the angiographic success rates were very, very high, so above 96%. But it's really the subsequent three sets of bars that I want you to focus on. Look at the fact that 2.5% of the stents were lost in the balloon angioplasty arm. Now, this is something that we would talk about when I trained. We really don't lose a lot of stents these days. But what that tells you is that, and there were no stents lost in the Rotablator arm. What that tells you is that the use of rotational atherectomy facilitated the delivery of stents in these complex patients. Similarly, 12% of the patients randomized to balloon angioplasty had to cross over to rotational atherectomy just to get the case done, and the overall strategy success was much higher with rotational atherectomy. So we had a durable result in this trial. It was similar to using balloon angioplasty, but overall the case was made easier because of the presence of the atherectomy device. Now, of course, we have orbital atherectomy, which was first piloted in the periphery, and now we have it for coronaries as well. This was studied in the Orbit 2 study. You can see the mechanism of action there in this cartoon. This is a little bit different from rotational atherectomy. It's an orbital path. It's not a burr, but a crown that's also diamond-crusted. And the Orbit 2 study was designed to evaluate the safety and efficacy of this diamondback coronary atherectomy device for enabling stent placement in severely calcified coronary lesions. It was a prospective multi-center registry. What's interesting about this was that there was no control arm. Now you may be asking yourself, why didn't they randomize this against rotational athrorectomy? Well, this was a study that was done for FDA approval, and there's no other device that's actually FDA approved for calcification. So they could not have a control arm in this study. So what they had to do was base it on what's called OPC, or optimal performance criteria. That's an FDA term. So based on what's known in the literature. These are the inclusion criteria for the Orbit 2 study. The important issue here is that the target lesion had to have some evidence of severe calcium with an arc of 270 degrees by IVUS, and the target vessel it had to be between 2.5 and 4. You can see the exclusion criteria there, pretty extensive, but that would be expected for an FDA approval trial. So this is the OPC. So the optimal performance criteria for this looked at the prior studies on atherectomy and said that the freedom from MACE within 30 days should be at least 83%. That is a 17% rate of major adverse events based on the type of patients that were studied in this trial. The freedom from 30-day MACE in the Orbit 2 registry was 89.6, so it clearly met the OPC for the primary safety endpoint. What about primary efficacy endpoint, procedural success? Well, again, the OPC performance goal, based on prior literature for similar types of patients using rotational atherectomy, was 82%. But with orbital atherectomy, it was 88.9%. So this is the study that led to the approval of the orbital atherectomy device in the coronaries, and the MACE study has just, I think, has recently completed and will be reported shortly. So this is the differences between the rotational and orbital atherectomy devices. The rotational atherectomy device, you all know, has multiple components like a foot pedal. Larger burrs do require larger guides. So if you're going beyond 175 burr, generally you want to use a larger guide so you can inject around it. You use very, very high speeds, 160,000 RPMs. You make very quick pecking passes. You don't want the burr to sit anywhere in the coronaries because it generates heat. It only ablates going forward, and it certainly facilitates getting through the lesion. Orbital atherectomy is a little bit different. It's a motor. It doesn't require a foot pedal. It's one console, one crown. It only is 6 French compatible. The amount of tissue that it ablates is dependent directly on the RPMs. So if you want to ablate more or a larger vessel, you don't need to change the burr or change the crown. You just simply dial up the speed to 120,000 RPMs. This is a device that you have to go extremely slowly. If you go very quickly with this, you're not getting any atheroablation. You have to go very slowly with this device to allow it to do its work and actually ablate the calcified plaque. It ablates both forward and backward. So as you go forward, it will ablate, and then as you pull it back, it will also perform atheroablation. The idea behind the orbital atherectomy is that it's FDA approved for calcification. It ultimately improves vessel compliance, which theoretically will enhance stent apposition and improve long-term outcomes, which is what the MACE study will ultimately prove or disprove. So this is the final result of this patient. We certainly could have done this with balloon angioplasty. My guess is that we probably would have struggled a little bit more. So this is a 6 French left radial approach, 4 orbital atherectomy passes at 80,000 RPMs, followed by balloon angioplasty, followed by drug-eluting stenting, and I think a very acceptable angiographic result. So to wrap up, the CHIP concept relies on the use of available tools to achieve the best angiographic and durable outcome, and atherectomy is an integral part of that. There's more than one option now, rotational atherectomy as well as orbital atherectomy, and given the kinds of cases that you've seen today and you'll continue to see this evening, the contemporary interventional cardiologist has to be facile with atherectomy. Thank you very much.